You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
I am a hypertension specialist, but first and foremost, I'm a primary care clinician, and I have was a practicing primary care doctor for over a decade before I started to focus on hypertension. And so I've certainly been in your shoes, treating patients and many patients with hypertension. And just to take a really big step back today to talk a little bit about why we're concerned about hypertension, just a reminder that about half of U.S. adults have hypertension and only a quarter have their blood pressure controlled. That's 125 million adults in this country with hypertension. So I'm going to pose this question, why? Why do we think that we are doing so poorly with hypertension? And I have some ideas, but I'm going to start by asking the panel to chime in. This isn't a lengthy answer. I'm going to cut you off if you carry on. But why? Why do you think we're doing so poorly? I'll start with Dr. Jones, and we'll move towards me.
All right. So I'm supposed to be answering questions, but I'll ask one to begin with. Does anyone in the room think it's fair for Dr. Basile to invite a panelist from Mississippi and someone to present cases from Harvard, right? I mean, really.
Now, you did work with Dr. Guyton.
All right. So that's a question that does have a long answer. We probably really don't know all of the answer of this, but I'll just say clearly, genes have not changed a lot over the last couple of centuries, but lifestyle has changed a lot. Yeah. This is a lifestyle problem. There are some of us who have genes that make us more likely to respond to the environmental exposures than others. So there's a genetic component, but the rates of hypertension that have accelerated over the last decades are related to lifestyle. And body weight is really a key part of that. Sodium is an important part of it. There are other things that we could identify, but those are important factors in the change in the rates of hypertension. There are still a few primitive populations in the world that can be studied, not many, but a few. But in those populations, blood pressure does not rise with age. Blood pressure remains relatively stable over a life course. And we used to describe this as a problem in Western populations, and that's no longer a term that we can use. Hypertension is a global problem, and it's there you go. So it's a lifestyle issue, and it's one that's tough to tackle.
So lifestyle. Dr. Tuttle?
Well, I think Dr. Jones has hit some big ones, but I think it's also allostatic load. It's chronic life experience and stress. And I realize that's a fairly generic term, but especially in some populations that are disadvantaged, stress and daily living is very, very challenging. So, and then there's the intersectionality of risks, right? Because the cheap foods are also unhealthy foods. They have a lot of sodium, but they also have lots of fat and calories, and then it intersects with obesity and then the other risk factors. So I think hypertension is important, but I think it often keeps company with other adverse life experiences and risk factors that, conspire to, lead to major health problems. And, we're now looking at least in the United States, a population that may have lower life expectancy, for the first time in a generation, maybe going the wrong direction. And there are contributing causes. I don't think it's all the pandemic. I think a lot of it is just what Dr. Jones said is unhealthy lifestyles culminating in hypertension, a clustering of risk factors that cause people to leave too soon.
So diet, lifestyle, obesity, stress. Dr. Basile?
I think our healthcare system is haphazard. In healthcare systems like Kaiser and the VA, where people are assigned a primary care clinician, the blood pressure control rates are much better. They use an algorithm. They know what they should do. They use fixed single pill combinations. Everyone's responsible for a patient. Patients know where to go. In studies that have looked at this, your ability to be controlled is much better when you are assigned and you have someone to go to and you don't go to an emergency room and you can afford the medications and you take your medications. You know, the most vulnerable populations in our country are more likely to know that they have hypertension and are more likely to be treated, yet they are less likely to be controlled. So I don't know if I'm allowed to say social determinants of health anymore, but I will tell you something that I did not really learn much about in med school, although I took a social history on all my patients. That is so important. Just the last two numbers of your zip code can really make a difference in the food you eat, the food you can buy, what you can afford. Do you have a roof over your house? And if we could minimize social determinants of health, a nice study that looked at this in the New England Journal of Medicine actually showed that we could make healthcare much more equitable for everyone. So there are a lot of issues, but I think we have to hold our patients accountable. We have to be accountable. We need patients to bring their medicines to their clinic in the bottles that are last filled. We need to make sure that they're taking their medicines, work with families, a lot of issues. But I have worked on these, and I practice these, and I use these in my patient care for many, many years.
Covered a lot of ground there.
A lot of ground.
A lot of ground.
Quickly.
So I'm going to latch onto one concept, and that was the concept of patients having a place to go for care. So here we have a nephrologist and 2 internists who can treat hypertension. What other types of clinicians might treat hypertension? Anyone? I heard family medicine. I heard endocrinologist. Emergency rooms. OBGYN, cardiologists. Nurse practitioners, thank you. Clinical pharmacists.
Oh.
Others? Come again? RNs, correct. More?
Physician assistants.
Physician assistants.
Yeah.
Community health workers.
Community health workers, barbers can treat hypertension. But what we have here is something that's called a diffusion of responsibility. When so many people might be responsible for treating hypertension, how do patients know, or how do clinicians know who is guiding the ship? And so my challenge for you today, I've been asked to provide cases so that we can apply some of the wonderful knowledge that we've learned today to actual clinical care. My challenge for each of you today is to go back to wherever you practice and take control of patients' hypertension, because we are standing and watching our patients die from complications of untreated hypertension because of a diffusion of responsibility, lack of communication amongst care teams. And so we as primary providers, however you are, whatever field you're in, take control and start to make some changes to get patients' blood pressure to goal. Because I think Dr. Jones said it best earlier, however you do it, getting blood pressure down is going to save lives. Okay. That's my soapbox for today.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.